Well, what an honor to be here, and I am a friend of Housecall Providers. Benneth and I go way back, and oftentimes in your own neighborhood you don't know when it's such a gem in the country, but you really have such a gem here, and I'm so excited to come and talk to you, which has become such a passion for both Benneth and I. The mission of Housecall is to improve the quality of life of homebound patients, improve the quality of life of caregivers, while reducing healthcare costs by keeping people out of hospitals and nursing homes and emergency rooms. And it's because of this last factor that we are gaining so much interest in the country in terms of what we are doing. How many people had a house call when they were growing up here? Yeah, and so why did it go away? Well, it went away for three reasons. Technology, as technology advanced, you had to go to the hospital or the office to get that technology because you could not do the same level of care in the home. There was a fear of liability, and finally there were financial reasons. Well, do these barriers still exist? Technology is absolutely not a barrier. This is me in 1994 doing an x-ray in the patient's home, developing it in the driveway and showing the patient with this nice view box that also serves as a window once I leave the home. But there are services here that do x-rays, that do ultrasounds. Here's an EKG. Now your own laptop computer, you just put the software in, and it serves as an EKG machine. Other technology, both Housecall Providers and my practice are on electronic medical records, so actually, in fact, probably not so good, but I was just doing some medical charts just before I got up here that were, one of my patients actually passed away at home on hospice, and that's part of what we do. Ultrasounds can be done in the home. This was a study done in 2011 that showed a ultrasound machine that fits into your pocket that was essentially just as effective as the big machine in the hospital, and they only gave them 4 minutes to use the machine in the home or in the practice because they wanted to simulate doctor's activity. And so technology is definitely not a barrier. This is actually my iPhone. It has 2 leads on the back of it. I can show you guys this later. And in 5 seconds, if I put my fingers on these 2 leads, you get your rhythm strip, your EKG, right on your phone. And so technology is absolutely not a barrier to doing quality house calls. I can actually do more in the home, and Benneth could do more in the home than we could do in our offices in the early 1990s. Liability is not a barrier. In the last century, even though there was a decline in house calls, in the last century there were 2 lawsuits out of millions of house calls. And so liability is absolutely unheard of. The patients love you, and so it really has been finances. And I'm not going to go through this much, but it just shows in 1997, my most common charge in Illinois was $59.37 to do a house call. At the time, home health was fee-for-service, and aides got $61, nurses got $80, therapists got $100, and social workers got $120. So I was the lowest paid provider to go in the home. And if you think about that, it kind of makes sense. When you think of home health, what do you think of? You think of nurses and therapists. Well, you actually got paid less to do a house call than if they came to you. Our National Academy actually got payments doubled from 1998 to 2004, and so now my most common charge is $135.18, and those increased payments definitely do help. But I sometimes say, try to get a plumber in your house for $135, let alone a doctor with malpractice insurance and a nurse back at the office, and so still, it really is finances. I don't know what Medicaid pays in this state. In Illinois, our payments are quite low. You can just see them there just as a for instance. And so it really has been finances which have led to the decline in house calls. But we're starting to see some innovative programs, in part led by the state of Oregon and Senator Wyden, that are bringing them back. I also wanted you to know that just in terms of conflict of interest, we do get paid other ways. I get corn and fresh eggs and apple and cherry turnovers, which is a good reason not to have a dark blue jacket. And in 1997, when my son was born, this patient who's on oxygen, homebound with emphysema, hand-crocheted this blanket for my baby. And so it just kind of shows you some of the relationships that we develop. But obviously, the reason you have to be able to pay your bills, but the reason why most doctors like Dr. Husted are in this is because we really want to make a difference in people's lives, but we need to also pay the bills. So the return of the house call. Why is it returning? There's 4 main reasons right now: demographics, healthcare reform, the Medicare and Medicaid fiscal crisis, and recent evidence of the value of house calls. And we're going to go through those. Everyone knows the baby boomers are aging. January 1 of 2011 started the first baby boomers entering Medicare. 10,000 new beneficiaries per day from January 1 of 11 for the next 19 years. 10,000 new Medicare beneficiaries a day. The most rapidly growing group is the lavender group here, which is the 85 years of age and older. And when you look at them, half of them require assistance for what are called basic activities of daily living. This is like being able to go to the bathroom on your own, get up from a chair on your own, dress yourself. These are really basic things, and half of people over age 85, which is the most rapidly growing population in this country, need assistance. And it really is an exploding homebound population. To drive the point home, we've had over 100 100-year-old patients, and this is just a couple of them. This guy was 102, my oldest at 111. And we have to get permission to show you these patients' pictures. And this 100-year-old gave me permission, but he wanted to make sure you knew. He goes, tell them that even though I'm giving you permission because I'm 100, that just because you're 100 doesn't mean you still don't have it. And so I promised him that. Number one reason the age in our society, it is just staggering. In fact, this Ken Dykewald, who's this famous guy, developed this thing, AgeWave. He's done a lot of things for different countries in terms of setting up their aging networks. But one of the things that he quotes, just in terms of the world never being here, since the beginning of existence, those who have reached the age 65, 2/3 are alive today. And you just don't realize, we've known about the baby boomers, we're living this, but we just don't realize how unprecedented, and we have to do things differently. And I think Housecall Providers is a great example of doing things better for less resources. And so going into healthcare reform, there's 3 aspects I'm going to go over. Readmission reduction, which you might have heard of, hospitals getting penalized for readmissions in the first 30 days, accountable care organizations, and then the independents at home, which Housecall Providers is a part of. This was one of the studies, New England Journal of Medicine, in 2009, that showed 20% of patients are readmitted within 30 days. What you often don't hear is that 34% are readmitted within 90 days, and in the first year, over half of people are readmitted. And I say to people, if this was your auto shop that you bring your car into, and you had to come back 20% of the time within 30 days, I'm not sure how much of us would keep going back to that auto dealer. But this is something that is really getting a lot of attention. And one of the things, too, that Housecall Providers and other Housecall organizations are focused on is getting rid of the re. We focus on readmissions because they're penalized, but one thing that they are huge about is just preventing admissions, period, because a lot of the initial admissions are also prevented. For half the patients that were readmitted within 30 days in this study, they did not have a doctor visit. And so that's something we can do. And there has been data out there that shows how wonderful Housecall Providers is. This is a study with nurse practitioners where they looked at heart failure patients. They gave house calls for the first 3 months. House calls stopped at 3 months. And what they did was they cut costs in half. They cut readmissions by 2/3 in the first 3 months. And then they stopped making house calls. And you can see over the next 3 months, even though the intervention stopped, there was still a dramatic reduction in costs and readmissions. But this didn't go anywhere. And why didn't it go anywhere? It cost money to send those nurse practitioners out, and the hospitals lost money because the patients didn't come back. And so there was no financial reason to do this, but now we have this data to show, and I definitely have some anecdotal stories. I was given a talk in 2011 in February to a bunch of hospitalists because we were starting to get word that readmissions were going to be penalized, and now my hospital, wanted to definitely try to avoid that. And so one of the hospitalists told me about this gentleman. He had been in 1 year, 9 months in the hospital emergency room 44 times, 27 hospitalizations, and over half required time in the intensive care unit. And so he kind of said, I doubt you can do anything about this, but take him on. And so we saw him first March 2nd, once he got out of the hospital, and over the next year, he went back once. Had he continued what he had been doing for the previous 645 days, you would have expected 25 ED visits and 15 hospitalizations, half in the ICU, and he went back once. That one time was one more time than he went back than in the next year. And actually, he moved away in April of 13 to actually go to Tennessee to take care of his mother. He was doing so much better. And so just a great, and so he was one of the younger patients. Our average age patient is 80, a third are over 85. I've looked at Benneth's statistics, and even all our statistics with these practices, because you track the same patients, are just incredibly similar. But this is a more typical patient, 83 years old, and is often the case with heart failure in our current acute care system. She was homebound, and she had in 2012 17 emergency department visits and 13 hospitalizations that included 69 days in the hospital and multiple rehab stays. We started to see her December 5th of 12. She did go back to the hospital 13 days after we initially saw her. You try immediately get things going, and so she did go back, and then after that, you really get them engaged in terms of that. She didn't want to go back to the hospital. We didn't want her to go back to the hospital. The husband didn't want to go back to the hospital, but she thought she had no choice. Well, we got things set up at home. We got home health. We got telehealth where they actually weigh the patient, do vitals at home. We told her one phone call to us, and she was actually on my way home. I could see her any day of the week. And we completely stopped her going to the hospital. Eventually, she did end up on hospice and passed away at home with no hospitalizations in 2013 on July 22nd. And this gets me a little bit into end-of-life care. In this country, 33.5% of patients as of 2009 pass away at home, and so about 2/3 pass away in institutions, which is why end-of-life care is so expensive in this country. Benneth and my practices are the opposite. We have 74% of our patients over this 11-year period passed away at home, and I think Benneth, when I looked at yours, it was even closer to 80%, so we're kind of competitive here. And so, and then looking at 1 year's data, I did this for a grant last year, ending August 31st of 13, 79% of our patients died at home, 71% were on hospice. I'd never looked at this before, and I was extremely pleased at our hospice rate. And again, I've looked at your data. It's amazing how similar these numbers are, Benneth. Our average length of stay was 2.1 years, which is the huge cost time of end-of-life care in this country. And because our median length of time was shorter than it had been in the past, I actually looked at our patients that were referred to us kind of at the last minute. And 25, so over 10% of the patients that died that year, actually we got referred in the last 30 days. And I was pleased to see that actually 92% of the time we were able to enable them to pass away at home, which is what they desired. As I talked about, the end-of-life care is just hugely costly in this society. A quarter of the $556 billion Medicare dollars goes to care in the last year of life. And if this was providing the best care, we'd have an ethical dilemma. Yes, it's costly, but it's the best. But statistically, if you want to die in pain and short of breath, die in an intensive care unit. You know, and if you want, and statistically, if you want to die in the most comfort and with the least emotional distress, die at home on hospice. And so, and this is just another way of putting it. This gets into kind of the accountable care organizations that I'm not going to go into, but they are responsible for costs. And Benneth in my practice just by default attracts the sickest of the sick. And I just found this slide from the Kaiser Foundation just very impactful. When you look at the 10% of the costliest patients in this country, they consume $55,763 per year. And if you look at the remaining 90%, which includes the 85 and the 75 and the 65, so these includes expensive people, it goes down to $4,584. And so what Benneth and I are attacking are these hugely costly patients, and not just reducing costs, but giving them such better care in the home. I have to, usually in audiences like this, I do not bring up independence at home because it's kind of technical, but the reason I bring it home is you should be so proud as a state because you are really being a part of transforming care in this country to the homebound. And so what the program is it's part of the Affordable Care Act. It was an amendment, the only amendment in the Affordable Care Act that got 100% support on both sides of the aisle. And it focuses on the highest cost Medicare beneficiaries that we've discussed, the 10% that have 5 or more chronic conditions and consume about 2/3 of the cost. And so this is what the patients have to have. They have to have chronic conditions, they have to have been in the hospital, they have to have functional dependence. What does the practice have to do? They have to save Medicare 5%. That sentence in the Affordable Care Act is the only sentence that requires cost savings. In the other 2,000 pages, there is not one other sentence that requires cost savings. There's a lot of parts of the Affordable Care Act that hope for savings. And I know readmission reduction, it will get savings. But this is the only sentence, minimum savings of 5%, they have to have good outcomes. So here's the patients, here's what the programs have to do, what do the programs get? Savings beyond 5% are split 80% if they meet those quality indicators, 80% to the program and 20% back to Medicare. So it's kind of like everyone wins. The patient wins, they get this wonderful care in the home. Medicare wins because they save 25%, and the program gets the support they need to hire more social workers and get the technology that's needed to truly keep these people at home. And I thought to drive home the point, I'd give a case that shows the difference of before and now under independence at home. This is in 1994, where I got called to see this 92-year-old who had had a horrific experience in the hospital 3 years earlier when she was 89, and the family absolutely did not want her to go to the hospital. She was out of it, not eating or drinking. They called us out. We found her to have 104.9 temperature. We had this blood instrument that could tell us how her kidney function was and her electrolytes, and it just confirmed she was just horribly dehydrated. Her potassium was critically low at 2.9. And so we didn't know where the temperature was coming from, and so I set her up for an x-ray. While my tech was developing the x-ray in the van, I started an IV of 0.9 normal saline with, for all you doctors here, and with 40 milliequivalents of potassium. So it had the potassium replacement in it, it had the hydration in it, and then the x-ray came back, the arrow was pointing at some white fluffy stuff that shouldn't be there. That's called pneumonia, okay? So now Dr. Cornwell knows what he has to treat. So I hung a gram of what's called Rosef, and I took some pictures and used the picture hooks to hang up some, and realized this is in 1994. We could have been doing this so long ago. And Bennett started in 92, a year before I started. But so when I took these pictures in 94, not for the Independence at Home legislation in 2011 or 2012, I took it to market our program. And when I would show these pictures to doctors, they would say, Tom, this is quite remarkable, but you are begging for a lawsuit. This is just so unconventional. This patient should be in an ICU, not with you tinkering her at home. And what I would tell the doctors is, you know, we know statistically the hospital is an incredibly dangerous place to put this patient. These were actually studies that were done before I saw this patient. There was one done out of Northwestern that found back then if you were in the hospital over 2 weeks, there was a 60% chance of a major mistake happening to you during the hospitalization. And then this really famous doctor, she's published so much since this time anyway, she found that there was a 34 to 50% decline in function unrelated for the reasons why they went in. And in this patient's case, it was typical back in 94 for her to go to the hospital, get a week of antibiotics, and never get out of bed. And now she can't walk, and so then she goes to rehab. And at home, they obviously kind of keep up their activities and things. And so, well, how did our 92-year-old with 104.9 temperature, dehydrated, hypokalemic do at home? This was her the next morning. Is that? Oh, no one's ever clapped. Yeah. And I tell you, and this room Bennett, is this a dream come true? Because we've been doing this for 20 years, and we've been seeing this for 20 years. And to have you in this room, you don't know what it means to Bennett and I to have your support. And just the support now of the country and the other speakers that I've talked to. And so going on the Medicare, Medicaid fiscal crisis. So Medicare, we know, is facing insolvency. They keep pushing it off a little bit, which is nice. Medicaid, and to me this is kind of sad, is Medicaid increased from 8% of state spending in 85 to 22% in 04, overtaking K through 12 education. So not only are we just wondering how are we going to pay for this, but what other things are we not going to be able to pay for because of how we're doing healthcare in this country. And one of the things I want to stress before my last data is that the most rapidly increasing Medicaid cost in this country is for long-term care. And finally, I'm just going to just have a couple more slides here, just in terms of some data. So I've shown you some neat stories, but this is some data from the VA. And Tom Eads, who's a past president of our National Academy, had this wonderful home-based primary care program in the Veterans Administration. And in about 7 years ago, because he was spending, as you can see, $11,000 more in his home-based primary care program than usual care. What was he told by his seniors? You're spending 4.5 times more on your patients than usual care. What do you think he was told? Oh, you're doing great. Oh, they love you. Their quality is, No, he was told, you got to cut it. This is costing too much. And he said to them, please give me a chance to show you the whole picture. And the University of Pennsylvania took their 2002 data. That's what they had to go back to in terms of getting all the data they needed. And they analyzed these other things. And what they found was an 87% reduction in nursing home days. They found a 63% reduction in hospital days, a $9,000 per vet savings that when you multiply it by the 11,334 vets in the program, came out to $103 million savings. And again, this is something that, again, Benneth and I have been kind of fighting about because I'm part of the health system, and they kind of look at your silo, but the whole picture is really quite extraordinary. And I don't like ending with statistics, so I'm going to end with one more story. And there's only one not so nice picture that you probably shouldn't show at breakfast. And I'm going to warn you guys who don't want to see it. It's just bad teeth, okay, just to warn you. But this is a patient who, if you can see the Elvis picture above the wife's head, he used to be an Elvis impersonator, and he got a severe neurodegenerative disorder. He's actually in his 40s here that caused him to be to just have a lot of difficulties in terms of walking and stuff like that. We have an assistance fund. I talked to Terry Hobbs, and they do the same thing where when their patients desperately need something they can't afford because of donations, I'm sure, from people in this room, they're able to pay for things. And we were able to pay for this lift chair. This other son of the couple here, he has cerebral palsy and cannot walk, and actually he has 2 glass eyes because of horrible glaucoma. And so here's this mother having to take care of the husband as well as the son. Well, he had the seizure disorder, and he would get these mouth infections, and I think it's the next slide that you might want to close your eyes. But this is just his teeth. And again, I don't show this to gross you out. I show it because these are the desperate situations that our patients that are in that just need help. And then I told the story. This is my dentist. I told the story to my dentist about this guy after I had his teeth removed. He actually did a free house call to the guy and gave him new teeth. Is that not cool? And so this is, how many hundreds of thousands of house calls have you guys made? Do you have any idea? We're at like 86, and I know you've got so many more provided.
Over 100,000.
Yeah, so they have made over 100,000 house calls, and I've showed you a handful here. And so I just cannot thank you enough in any way that you guys have supported them, just being here today, for your support and stuff like this. But again, I need to thank you as president of our National Academy. Senator Wyden has been the greatest proponent on Capitol Hill in the Senate. Representative Markey, who is now Senator Markey from Massachusetts, they have so championed, and in part because of Bennett's work here and knowing the difference this is making, and truly it is making such a huge difference in their country, as we need to figure out a better way of taking care of the most expensive population in our society. And I think Housecall Providers is finding a way. So thank you very much, and I look very much forward to hearing from our other speakers.